Good afternoon, everyone. We are delighted that you are here for session 2, COVID-19 Best Practices in Long-Term Care. I am Susan Ryan. I'm the Senior Director of the Greenhouse Project. And if you don't know the Greenhouse Project, it is a radical transformation of long-term care, building upon the core values, real home, the physical environment, meaningful life, and that is really all about the philosophical culture. And last but not least, the human architecture, and that we call empowered staff. So on today's session, we are going to be talking about the second wave and what we need to do to be preparing for the second wave. We're using an ECHO model, and I love ECHO because it really is about leveraging technology to be able to enable us to share, identify best practices. We use a case-based learning, a scenario-based, and then we really monitor that quality and that outcomes. Before we get started today, I'm going to have my colleague, Janet Wright, go through some logistics. She will be supporting our technology today, and she's going to go through some housekeeping. Janet? You're on mute, Janet.
I'm usually always on mute, so I always forget to do that. So welcome everybody. Please, we do ask you if you would like to share your camera. We'd like to see who is on the call. You can also add your name and your organization to the chat box so that we can sort of take attendance through that system. You'll notice that at the bottom of the screen, that's where you can share your camera. If you click on the video camera icon, that will share your not your screen, but your picture. And if you click on the microphone, actually you can't click on the microphone. You will be muted throughout the presentation. So you will be able to use the chat box to enter questions for the speakers once we get to the question and answer portion of the presentation.
Great, thank you, Janet. And the session is recorded and you will get a recording of this. I'm gonna ask my colleague Marla to join us and introduce herself.
Hey everybody, Marla DeVries. I'm the Director of Resource Development at the Greenhouse Project. And I will be jumping in throughout this presentation to help with some of the Q&A. So just want to encourage you to use that chat box to ask your questions.
So speaking of questions, you know, this is where we really have some give and take, and we really want to hear from you so that we know how better to tailor our presentations. So what has been your greatest COVID-related challenge for the month of July? So I want you to type your answers in the chat box. So have at it, type your answers in the chat box. What has been your greatest COVID-related challenge for the month of July? So while you're doing that, Janet, I'm gonna ask you to launch our first poll. It's really exciting to be able to take advantage of the polling feature of Zoom to really figure out a few things about who's joining us today. So here's our first poll. And we really want to know where you are from. And you saw the map, so take a look at the map and identify which region of the country you are from, or outside the US as a category as well. So we'll give that just a few minutes. About 50% of you have indicated where you're from. Wait just a few more minutes, or seconds, I should say. All right, why don't we close the poll? It looks like, again, most of you are calling in from the Northeast. And let's see, what else did we learn about this? And some from the Southeast. So welcome wherever you are from. We are glad you're here. I would like Al Power, if you want to introduce yourself. Al Power is a subject matter expert on our ECHO. Al, you want to introduce yourself?
Certainly, Susan, thanks. Hi, this is Al Power. I'm a geriatrician and educator consultant from Rochester, New York, which is where I'm sitting right now. And I've done number of projects with the Greenhouse Project over the years, including being one of the usual suspects on this webinar series. So welcome, everybody.
Great. Welcome, Al. Eric Riguera from Jewish Home Family, would you introduce yourself and say hello to everyone?
Right. Again, thank you for having me back. It's a pleasure being with the Greenhouse folks. Again, I'm the Director of Nursing here at the Jewish Home at Rockley, located in Bergen County, New Jersey. Thank you.
Great. Thanks, Eric. Always good to see you. Jill Wilson, we are thrilled that you're with us. So if you want to introduce yourself to our group.
Hello, everyone. I'm Jill Wilson. I'm the President and CEO of Otterbein Senior Life, whose home offices are in Lebanon, Ohio. Good to be with you.
Great. And we will hear more from Jill in a moment. And last but not least, Tammy Marshall, introduce yourself. And then I'm going to have you go ahead and launch your presentation.
Thank you. Hello, everyone. My name is Tammy Marshall. I'm the Chief Experience Officer for Thrive Senior Living. We are what we call boutique luxury senior living, mostly in the Southeast and a little bit toward Texas. Some new stuff going up in New Jersey. So happy to be a part of this call. And I'm going to share my screen. And here we go. So part of this talk, I just want to start right off with saying the word compulsive sometimes has a negative connotation. And so this whole presentation is really in context, obviously, to how we communicated in our strategies around the pandemic, and specifically with our residents, families, and team members. So compulsive communication became our right out of the gate February 29th strategy, both because our culture is one of high communication and profile, but the families and the residents, as you all, I mean, nothing I say today, by the way, is you're going to be like, yes, we've experienced it. Because if you're in the long-term care spectrum, you've experienced almost everything I'm going to say. So my particular point in presenting is to share some of the strategies that we found to be very effective through that. And compulsive communication for us meant both the families had an irresistible urge to hear from us, and we had an irresistible urge to share. That's just kind of the way that if you Google compulsive, it's like a irresistible urge to do something. You can't control it. And on both sides, families and residents, and in terms of the organization, we both had an irresistible urge to communicate. And why? Because there was so much unknown. And for us, that's ambiguity. And that word, again, I'm playing on the words here, ambiguity scares a lot of people. And I'm gonna pass this one. So I'm gonna go back. Why we know that we needed to go to a compulsive communication model. One, because there were so many competing data points and pieces of information. And we started logging the amount of calls we were getting. And literally, this slide was where the organization was at early on. Families, residents, team members, hanging on every word we said. So anything that we put out publicly, either media, camera, written, push text, every word was particularly chosen. And then we had a marketing firm that also coached us. That's how important communication became to us. And because of the seriousness of it, knowing that people were hanging on our every word, literally, I'll share the strategies that we went about to help people bring comfort. I see the cartoon stock thing did not come off of there, so that's really fun. Appreciate that. So sorry about that. So anyone with a phone, and it depends on where you are on the spectrum of whether you like social media or not, or Facebook and all of those things, or if you have children or partners. But all of us probably on this call have some level of dependency on a smart device. And so just the joke play on this is that the dependency on the phone for us became this joke, a parallel on the family's dependency and the residents' dependency on us for communication. And so that is another way that we decided, like, the amount of times the phone rang or that all of us were getting texts, we realized that it went from the average call between 20 to 30 per week to, you know, hundreds and hundreds of calls coming in to the main offices, trying to get questions answered that lots of times we didn't have answers to. We gave answers, and I'll share our strategy for how we gave answers. But again, we were in the middle and continue to be in the middle of a lot of ambiguity around COVID, and compulsive communication was our way to go about bringing a level of certainty to it. So one of the things that we talk about internally and that we talked about with families, we were very honest. We even wrote an article about certainty, and that everyone is craving that right now. Probably most of us on this call want and crave a level of certainty. And then if you think about it for a minute, just a minute, a second, it's really not attainable. Certainty is not attainable. It's like the moment that you're breathing, you know it, the breath is the next breath. You don't know what's going to happen in the next set. So we, right out of the gate, said to families, what we write today, tomorrow, or within an hour may change. We want you to join with us to know that we are on a spectrum of ambiguity, and we know you're craving certainty. And then we did the same message internally with the team members. We did, you know, like most of you probably, daily calls. We still do our daily calls with 200 people on the phone, 3 o'clock, never fails. And we're doing both the science of COVID and the art of handling the pandemic. And one of the ways that we do that is take these mental models that people crave, operate under habitual patterns, and talk about them. And one of those things that we talk about is we want answers and certainty. And how do we help each other and support each other, knowing that there is no such thing right now, that tomorrow it could change, and helping people navigate their own feelings of fears through what we would call that swinging pendulum of ambiguity. So you've heard this term, hammer and dance, around COVID. So, you know, if we think about who gets called the hammer, the country like South Korea, China, they were considered the hammer folks. They just came in hard, contact tracing, texting or testing, and just really initially were able to handle the outbreaks fairly well. And then, you know, depending on where you live in the United States and other countries in the world, and literally what state you live in, you might have been dancing. And so we did a whole series with families around our strategy of what we would call the middle way. And we wrote about the middle way. Where we hammered is around testing. We were the first senior living company to test everyone, we just started testing everyone, no matter what. We didn't wait for symptoms. The CDC for the first, as you know, several months, if you are symptomatic, please test. We decided to test routinely, biweekly, without any executive order from the state, without any local health department. We just started testing and secured our lab. That offered us information on the status of the community, and we caught outbreaks immediately. And when I say outbreaks, we knew, you know, within a week or two if a team member had it before it ever actually reached a resident. And we shared that with families. And where we danced, and dancing for us meant not always following the CDC rules and telling families that we didn't, because it didn't, I don't know if there's anybody on the CDC either, but it didn't line up with our culture. So we stayed true to our culture. And one of those, like, for example, the dance on testing, we went outside the range for that. Even on some of the quarantine and isolation rules, we felt like we could dance a little more based on our level of information we knew about the community. And again, the reason why I'm sharing that is we shared with families daily, every single day in a letter. I'm still doing daily letters to families. And if you had an outbreak, you got a daily letter. An outbreak is 2 or more in our lens. So if you had 2 or more in the community, you got a daily letter from myself. And then everyone still continues to this day to get a weekly letter. And we talk about where we're hammering and then where we're dancing. And then we have chat email lines where they write us back and give us feedback on how they feel like we're doing. It was very, and this is the reason why I chose this slide, because the loop of interconnectivity and interdependence is really what we were doing with Dancing with Families and Residents. We didn't just come out with our rules. We took the feedback from the family. Every community had a helpline directly to the COVID team, and we shared around the clock Q&A, literally around the clock Q&A. So here's just one of the very basics. Some of you know this strategy on the call, I'm sure, but our culture, we have a core philosophy of radical transparency, and for us, that means we share with families, residents, and team members the information we know. And that means how many COVID positive residents we have, how many COVID positive team members we have, our testing cycles, isolation protocols. There wasn't anything we didn't share with families that we didn't share internally. Some people balked at that. I remember when I called our risk manager broker around the level of risk that we were taking, sharing with families. And, you know, of course they said, absolutely don't share your numbers. Absolutely don't share information about your policies and procedures unless you're asked. And again, we didn't follow any of that. We knew from the kind of tone and tension that we were receiving from families that our strategy was going to be compulsive, radical communication and transparency. So here's just one thing on, you know, hundreds of calls. Call would come in and say, we would train people to script this or say, this is what I heard you say. You're afraid of getting COVID. And this could be a team member, it could be a resident, it could be one of the contractors or essential healthcare workers from hospice. And they say, train people on the script. And I say, this is what we know about it. And we would share all the things we knew about the virus, the high risk, the low risk. We would ask questions about where they fall in the spectrum of autoimmunity. Lots of people taking these calls weren't clinicians. They were literally walking through this script and reading the CDC information. And then asking, always closing was that helpful? And then ending with how they felt now. Sometimes you would get to how they felt now and you would go right back up to the top and start over, because it was just a cycle of fear. But hundreds and hundreds of calls. We're probably down to, you know, maybe 25, 30 calls a day, but people are very aware of this script. Everybody got the lesson on how to walk someone through the cycle of fear and just bring them kind of, you know, as they say, off the ledge of worry and tension. Just checking my time. So here's just some of the methods we used. Everything we did from family letters and all of our videos, messaging and so forth, Facebook, emails. We developed a workplace site internally. We pushed text to families, team members, and residents. Of course, our website always had our daily COVID. We, again, like I said, 3 o'clock daily calls still happening today. And then an enormous amount of letters, which, you know, initially felt like an overwhelming task, but, you know, still, I 2 days ago opened up the feedback from families, how appreciative they were. You know, we all hear the stories, they're sitting at home wondering what's happening. And so a letter that changes their whole kind of aura for the day was well worth the hundreds of letters that we wrote. This particular thing I want to share next is another strategy that we went about in terms of how we were going to relay the message of COVID. Probably around the end of March, our particular senior management group was really getting frustrated with the tone in which our world, our field was being portrayed. That, you know, we've got these folks behind closed doors, nobody can come in, we're treating them, you know, like animals, and you name it, you've heard it, especially in the nursing homes. Senior living didn't take it as big a hit, but the nursing homes absolutely took a hit on how COVID was being portrayed. Now, while I'm saying that, there were a lot of awful things that did happen, and they were absolutely deaths. But on the spectrum of the pandemic, I can't tell you how many wonderful things happened in there. And I'm just going to share 3 minutes of this. This series is, we shared this series with Asha and Argentum. You can go on the website and find it. I'm just going to show you the resident version. So why is this important? As a senior management team, we all geared up and went into the COVID positive environments. And so everyone took a community, and where there was an outbreak, it could have been 2 or it could have been 25. We've had people up as 25, as high as 25. We would gear up, go in and talk to the residents and the team members. We'd actually use that same script. What are you thinking about? Give me a question, working through all of it, all the way down to how you feel and back up again. But we actually had so much fun doing this, even, behind layers and layers of PPE. So here we go, a few minutes of it. And really what this shares is, this is inside a COVID outbreak community. This particular one had about 32 and was 140 suites. And this is kind of their experience. We did it purposefully. So the news and the media didn't get to tell our story for us. In North Carolina, we had cameramen hiding in our bushes, videoing our people that were sitting outside, trying to tell a story that wasn't true. And so this was another way we went about communicating our story, not letting someone else take charge of it. So here we go. It worked earlier, so I'm keeping my,
She's getting it.
Oh, going down?
Uh-oh, we're gonna get low. Oh, she's getting some exercise. She's getting some exercise.
Tribute at One Loudon is an assisted living and memory care community located in Ashburn, Virginia.
Well, I feel safe in here.
And like hundreds of other senior living communities across the country, recently found out about its first group of COVID-19 positive residents. And yet life continues inside.
You step in it, you knock.
Hi. Hey. Ciao. Hi. This is a beautiful lady.
Hey guys, Les Stretch here, president of Thrive Senior Living. And if you've seen the news lately, you've seen the stories of nursing homes with 60 and 70 residents who've passed away due to COVID-19, and our hearts break for them. What you can't see because of visitor restrictions, neither you nor the media, is what's actually happening behind the walls of senior living communities across the country. And so we thought we'd show you.
I can remember the first day that all the positives started rolling in on the second floor, and that day was just mind-blowing. Like literally I just wanted to just cry. I didn't have any, it was just, it was real, it was here.
It was almost like, okay, it's here now. So now we're gonna do everything that we've been talking about.
What we're doing currently is just spray all the surfaces and we leave that liquid there. And what you're actually going after is a 10-minute wet contact kill time. And it's proved incredibly effective both to maximize the effectiveness of the chemicals and also to maximize our ability to clean large areas in a large building.
When you first heard there was a virus, how did it make you feel?
I haven't had the virus.
I know, that's what I was saying. When you heard it was out there.
I was scared.
I bet.
I don't.
Yeah.
It bothers me.
You know, there's definitely an initial shock and it takes some time to process. And I think people are scared and anxious.
I want to be respectful of time. For sure. But this, you'll have this, and because I'm very conscientious that I want to make sure everybody has their time. But when you receive the deck and the information from the Greenhouse Project, there are 3 videos in here. So this particular one is the resident experience. And you're going to hear from the families. We interviewed families. Actually, NBC News and ABC News put the family one on TV because there's a couple in here where you literally are talking to the residents, like feeling and them describing what it's like. I'm going to pass through these. What it's like to live in a COVID environment, and then for the families and team members to share their experience with us through that. And so just as our way of compulsively communicating our story, not letting anyone else tell what the COVID environment is, because we were trying to take all the myths out of the mass media. Yes, some of it was true, but the mass media didn't tell our story correctly. So all other things we did around compulsive communication was we did a lot of wordplay. So everyone was sick of PPE. So we said our version of PPE is our personal mindset we did every day with everybody. We got 3 o'clock calls, 200 people. What's your personal mindset? Are you possibility focused today? And then empathy always. I'm going to rush a little bit because I don't want to. And so in general, I would say that we've had more praise and compliments on compulsively communicating. We got more pushback from the health departments and our attorneys and our risk managers that we were oversharing. But I would say the main strategy that worked to help families and our customer satisfaction scores did not, they didn't dip. They, we had, even in the COVID positive settings, we had upward trends, and we credit that to the compulsive communication and actually not following, the risk manager's advice per se, because again, back to our 2 words, in times of ambiguity, people were seeking certainty. The only thing we could do is give them the information we had and tell them that it could possibly change at any moment, but they knew what we knew in the moment, didn't hide anything, and the trust factor has just kept going. And that's it.
Tammy, thank you so much. That was incredible. I really learned a lot. So I'm going to invite everybody to put your questions in the chat box, and we'll go to your questions in just a moment. We won't be able to get all of them, but we will try to, Marla's going to try to group them in themes. So Eric, Al, and Jill, as panelists today, I just want to open it to you to see if you first have any questions for Tammy.
Just a comment, what Tammy and her crew did, that's amazing. That's a lot of, that takes a lot of work and effort to do that, by the way. And part of our challenges also during the beginning and during the height of the pandemic is about communicating to the family members and the elders as well, because there's a heightened anxiety. And what's happening is we're getting bombarded with phone calls as well. So we made a strategy talking about transferring and changing of the role and shifting of the roles as well. What we did was our nurse case manager, nurses, what we did, or nurse, we made her as a liaison. She's the main contact person. So if the family members cannot contact the unit, what's going on in the unit because it's super busy, we have a liaison who's been available all the time and relay the messages to the nurses. That really work effectively. And also what we did before even the DOH initiated, we always send at least more than twice or 3 times a week, to do letters to the family members as well. And that really worked. Carol always sends us letters to the family members and also with the staff, because they need to know what's going on in the building. As what Tammy said, you have to be transparent. Family members will find out no matter what. Yeah. You have to be transparent, and that really works. You have to be transparent and truthful.
Tammy, I'm curious, you say you have a daily phone call and you have hundreds of folks that attend that call. And so you have multiple locations. What is the subject every day of those calls? How are they, how is the agenda formulated, and how do you get to the individual issues, I guess?
So what makes up that number is we have multiple communities, and every single leadership role is on that. So every community has 7 leadership roles, similar to everyone on the call. The content always up front is we do our point prevalence information so that everyone has the status of the company-wide. So who has, what are the numbers company-wide? Then we zoom out to, executive orders and local health department orders. So we're in multiple states. So we share that across the grid, because what we do with that information is, let's say we're in Alabama and they just issued porch visits. We call up the North Carolina folks and say, North Carolina's doing porch visits. When are porch? And we kind of work the health department, if you will, to get us to be able to do porch visits or whatever else the barriers are. So that's the first half hour. The second half hour, the first half hour is completely the science of COVID and the status of the community. Second half hour, like Tuesday, is a content topic to keep us united. So this week was the topic of interdependence. And so President comes on, we do a talk on interdependence and how each of us are our unique roles are supporting COVID. So it's very much the science and the status of the union, if you will, and then some kind of culture content. And that's right out of we have a culture deck. So we pull content out of that and say, how are we applying interdependence during the pandemic? Last week, it was, how are we applying, it's called leadership and self-deception. So it's very possible that during a pandemic, you might get off with one of your coworkers because it's a very high stress time. And so when you are sometimes off with a person, could be a relationship, coworker, so forth, you have a tendency, unless you do the work on figuring out why, to put them in a box, and everything they say after that, you say, oh yeah, that's what she always says. That's what she always says. And you just do it. And then it becomes a habit, and you see that person say, oh, I know what they're going to say. Mm-hmm. So we intentionally say, are you in the box about anyone? And are you willing to think about who you're in the box on, and consider putting a toe outside today? Things like that. So content is broken up half hour, half hour.
Thank you.
I'll just make a quick comment. I know you got a lot of questions, Tammy. It was really, is my sound better, by the way? I would switch to Bluetooth. Really great presentation, and just a wonderful initiative you've taken on. I just want to once again emphasize and applaud you for going your own way and not necessarily taking the advice of the people that said you shouldn't do this. What I've learned from being involved with change and upsetting a lot of people over the years is that the biggest thing to do is to communicate with people. You need to be honest. You need humility when you do it. And there is ambiguity, and you need to understand, to admit that you don't know everything, but you're doing the best you can. I think that there's a lot of distrust of authority nowadays, whether it be medical authority or whatever around the country. And part of that is the lack of transparency about what's going on that we have seen from different aspects of leadership. Everything is a conversation. And, you know, as a doctor, you know, with zillions of communications about malpractice over the years, what the attorneys tell you again and again is bad outcomes happen. The number one liability factor is poor communication. And I think that you are absolutely right to share with people. I'm assuming that the residents are okay with the people you shared it with, you know, because
you're on
ultimately,
our
yeah, good, good. But you're negotiating risk. And we often have statutes in long-term care that put us in a bind between safety and quality of life, where there is no right answer and you can get in trouble no matter what you do. And in those cases, you do the right thing. And I think you absolutely did the right thing. And I think that the response of your residents and families has really affirmed that for you. So thanks very much for doing that.
Great, thank you, Al. Marla, I'm going to turn to you to see what questions have come up in the chat box.
Yeah, so a lot of positive comments. I'm going to give one question. It's kind of a two-parter. So Tammy, was there family involvement to really inform your communication strategy? How did family input impact that? And then how has it evolved over time, over the course of COVID?
So in the beginning, we were very CDC-ish in our language and in our communications. We, you know, first couple of letters were very much, you would get no feeling out of them, and you would get pure CDC spewing, I would call it. And right away, they were like, need details. So boom, what kind of details you want? We had chat boxes and phone calls with families. We want to know where it is, who it is, if they're willing, how we can support them, and how long, you know, they wanted all the details. So definitely informed us there. And then we realized how regionally different people were. You know that intuitively, but what we got away with initially in North Carolina writing a letter, and let's say Savannah, Georgia, the Washington, D.C. folks were like, nope, every single little detail, you know, edited. And I don't know where people live on this call. I'm just sharing that we had a regional approach to letter writing because some of the ways the families were giving us feedback, we weren't getting away with a blanket letter. It had to be a regional approach.
Nice. Just one other quick one. So you said you really trained people with that script, with that radical transparency. So who were you equipping to do that?
So again, those 200 people on the call, they're the 7 leadership roles. And then you would med techs, because they were there after, you know, around the clock with the residents. And, you know, they would find people in a room in their suites and looking kind of forlorn, and they would just walk through that. So med techs and the 7 leadership roles, everyone had the script. Lots more people obviously learned it over time. We've been doing this a long time, but initially that was the big push. And equipping them with the other information so that as the question evolved, they had the data points to do it. And we had helplines. Again, we were helplines all the time.
Great. Great. And turn it back to you, Susan.
All right, thanks so much, Tammy. It was really a super presentation. And now I'm going to invite Jill to share her screen, and she's going to share a scenario that occurred with Otterbein. Jill.
Okay, I'm going to try this. Let's see, where did it go? All right. Well, good afternoon, everyone. And Tammy, thank you for just a great perspective on communication. I have several ideas now that I can't wait to incorporate into my organization. So just very quickly, Otterbein Senior Life is a faith-based nonprofit organization affiliated with the United Methodist Church. And our mission is in keeping with our United Methodist tradition. We seek to enhance the quality of life and holistic growth of older persons. And that's important to us. And we have a strategic goal, which is to lead the nation in liberating elders and those who serve them from the mindset of institutional care. And that's sort of the backdrop of this whole COVID situation. Just very quickly, we have 17 organizations, and we have at each of those organizations, we have 6 full-service retirement communities, home health agency, hospice, and we have invested a lot in the small house or the greenhouse. I think we're the largest, or at least one of the largest providers of this type of nursing home care in the country. We have 10 locations of small houses. And these are just some of the pictures. So I want to talk to you a little bit. Before I do this, I kind of want to back up because I don't want you to start reading all those squares. I want to share, this was about preparing for the second phase. And I think maybe the name came up when we thought maybe there was going to be an end to the first phase and then a second phase, right? So I kind of would like to retool that perspective and say, I think that the COVID crisis is over, in that we all kind of went through this crisis mode where, you know, what are we doing? How are we doing it? It was crisis. And now we're into the living with it mode, right? And so I guess I would say, here's kind of my story about how we're going to live with it. And I'd also like to say that one of the things that we've decided is that COVID's not going away. So when we wake up in the morning, we're not disappointed, right? And we can then reframe our mindset as to here's how we have to live and carry out our mission, which has never been more important to us, of enhancing the quality of life and holistic growth of older persons and still liberating them from the mindset of institutional care. So we were terribly unlucky, and I guess I would say sort of lucky, because in the beginning of the crisis, we were hit really early on, hard, at one of our locations in Indiana. We had a OT therapist who had been off work for a week, and on March 20th, she called in to say she had COVID. The next day, we had an elder who was at the hospital. The hospital called and said he had COVID. Within a week, we had 38 people with COVID. That location has had 100 total folks with COVID, and sadly, 16 folks passed away. So we had that situation that basically started right when we were closing things down. And And what we learned, I think, is what Tammy learned, that we could not rely on our health departments, the CDC, to provide us with answers. The best route, and I'm glad to hear Tammy's experience, was that we were learning so much more quickly, I think, maybe than other folks, because we were dealing live, real time. So we took the position that we needed to decide what to do based off of our own experiences. And so there still is. It's still shocking to me that people are talking about, you can't get tests, you can't pay for tests, you can't get PPE, you can't do this. All of that is a misnomer, in my opinion, if you've resigned yourself to the fact that this is not going away. So we decided that we needed to send a strong message that we were going to take the offensive, right? We were going to take the offensive and fight this and battle this in a way that would serve everyone and take out some of that ambiguity and uncertainty. So we launched what was called the Otterbein Offensive. And we communicated that to all of our elders, their families, our partners. And the Otterbein Offensive was basically developing an algorithm of testing that doesn't rely on symptoms. And we called it the Otterbein Offensive because we knew it was going to be an incredibly complex a complex operation to carry out, and we needed everyone to believe in it, to understand it, and to be receptive to it. We especially needed our elders and our families, but also our employees, which we call partners, because we knew that they were going to have to be involved in conducting tests and retesting and retesting and retesting and retesting. So I sent a personal letter. It was updated, and we frame everything in the name of the offensive. And so what you're seeing here is basically our testing tree, and we have actually a program that tells us who to test, when to test. That it shoots out based on the results what the testing schedule is for the next week. We're doing 1,300 tests a week in our organization. Tammy, you might be doing more than that.
I'm shaking my head.
And it is proving fruitful. It's proving very fruitful. And again, framing it as the offensive has gone a long way towards families being supportive. So we all have our curves. You can see these are, even though we're doing all this testing, these are our positive results between our employees, our contractor, and our elders. And what you can see is that, in the beginning it was pretty dicey because we knew any one of these could be that OT therapist that started 100 positive tests, 16 deaths. We knew that. And so you can kind of see how happy we were. And I think that's when maybe we were thinking that this was the end of the first wave in May, June 1st, June 8th, and then boom, right back up, right? But we never let up. We never let up on the testing, and we continue to do it. And if you look, just as by way of, is it how many elders have it versus how many of our employees, we call ourselves partners, and contractors have it, you can see that, as our folks were in the community, were getting out in the world again, they were getting it, and unfortunately this thing is so contagious, as we all know. As we look at what we're trying to accomplish, we're trying to avoid the blue. Okay, you see the shaded community, the blue, and you can see we've broken this down by residents, by partners and contractors, and then total. And you can see that really, because of this strategy, we can't keep it out. You know, I wish I could tell you we can keep it out. Tammy, I don't know. We cannot keep this out, but we can spot it early on. We can spot it early on and take measures immediately. And so you can see that thankfully we have been successful in really preventing another terrible situation. The shaded in orange represent the locations that still are at zero. I would say that it's interesting to me that they are all our small greenhouses, and I think those neighborhoods of having houses that aren't connected and are I think serving us very well in managing the spread of this just by design, So you know, what we've done is we've operationalized COVID, right? You know, with the communication plans, everything. I'm sure you all have too, but we've operationalized it. So when we wake up in the morning, we know we've got testing going on. We know we might get some positives, but we know that we can manage it and deal with it. So now that we've operationalized that, we can start. We know that we can live with it, right? We can live with that, and then continuing to focus on how do we enhance the quality of life and holistic growth with COVID. And the way we've decided to do it is to know that it's there and just accept it and make it part of one piece of our operation, but not defining us, not defining us. So that's sort of where we're at. And we're lucky that we were able to find labs. They're out there, guys. The labs are out there. They can do the testing. The cost is covered by our elders insurance. We've negotiated low rates for our own self-insured employees. And I see us having to do this, and we're hoping that there's an easier way to test. You know, we're all hoping for a vaccine, obviously, that's the number one thing, but we're always looking for an easy way to test. As a matter of fact, we had ordered 6 Sophia machines from Quidel, and 2 came in and the other 4 not. The Sophia is a testing machine that allows you to get individual results in 15 minutes. So we got 2, and then we're like, where are the other 6? Well, the US government has confiscated all the supply of the Quidel, and that's what CMS now is going to be sending out to all the nursing homes per their recent announcement. So that's our story. I don't know if it's helping anyone, but that's where we're at.
Jill, that was fantastic. That was really good. And I still love the proactive approach and the Outerbind offensive, if you will. And certainly you and Tammy must be cut from the same cloth and not really waiting for CDC or everyone else to figure it out or to kind of get ahead of that. So please put your questions for Jill in the chat box. And I'm going to turn it to Al and Eric and Tammy to have the first line of questions for Jill.
Jill, thanks so much for the presentation. It was really great. And to me, once again, this shows that the correct response in this type of situation, as difficult as it is, as you say, to take charge, to not have the magical thinking that this is not there. We've known that we've been at risk for pandemics for years and years. So we can't pretend it's going to go away or that we never have to worry about this. And really avoiding the politicization of this, going with facts and saying, this is life. How can we take control? And I think there's a real resonance with what Tammy said, because the biggest fear comes from lack of control over a situation. And when you control what you can, then the stuff you can't control becomes much more manageable. And you probably all saw the report that just came out of McKnight's this week that cited a study that said that when people go from building to building in long-term care, there's a much higher risk of COVID spread. So the idea of not having people floating from one community to another, I think that speaks to the low incidence houses you have, but it also gives us some messages about moving staff from building to building, moving agency people from building to building, even moving professionals like doctors and therapists from building to building. At this time, that's something that does increase risk. And so once again, I just want to congratulate you for really taking charge of a very difficult situation.
Thank you.
Tammy, Eric?
Just a comment, what Jill and your staff are doing. This is great. You know, even though there's no mandated memo from the Department of Health, you guys are doing it very proactively already. I know we're doing the same thing what we have here in the state of New Jersey, and I know it takes a lot of manpower to do it.
Mm-hmm.
We just did. Actually, this is our cycle today to do this week to do point prevalence testing. And since Monday, we tested almost 300 staff members and elders already. Right now, we tested a good 2,400 tests already that we did since we initiated on May 13. But the good thing with this is it gives you an assurance, you know, what's the status of the building, because you are identifying asymptomatic elders or employees. That means they have no symptoms, but you're identifying if they're positive, which is good because you're cohorting and making sure that they're giving a days off. So that is very proactive. And again, you have this intervals when you test them and you have that another cycle again. So it's a great approach. For us, it gives us a sense of security and comfort that we know what's our status in our buildings. So kudos. Very good.
Agree. Thank you.
Tammy, are you with us? Any question from you? And Marla, I'll have you pull up the questions from the chat.
Sure. So there's a little bit going through the chat. Can you confirm, Jill, that you said 1,300 a week?
1,300 a week, yes. We've actually done 18,000. Remember, we got a lot of locations. Yeah.
Wow.
My mother-in-law has been tested 4 times.
And you mentioned that insurance pays for the test. Can you elaborate on that a little bit?
Yeah. So one of the things that we can all make judgment about what the governments have done that's right or wrong. But one of the things they did is they increased what they would reimburse through Medicare for the COVID testing. They increased it to $100, right? So Medicare, as long as you have a physician order, Medicare or our elders insurance will cover the cost of the test. And what that did is it allowed all these labs who had the capability to do the testing but didn't think the money was good, they came off the shelves and started building capacity. So yeah, and then the other thing is, yes, there's a cost to, we have to pay for our own employees because we're self-insured, right? But for employees who have insurance elsewhere, their insurance will cover it. For employees who have no insurance, our lab bills through the CARES Act, right? And the other thing is that, we're not paying $100 a test. We negotiated a low rate for our own employees. And by the way, we're going back to renegotiate to get that lower even more. So this notion that we can't afford it, again, I think is a bit of a misnomer. It's not. You don't have to cover the cost for all the tests. There is a cost, but not what we all perceive or we're hearing in the media, in my opinion, in my experience. And that's what I'm relying on, my experience.
Jill, is it possible for your physicians to write blanket orders, a few weeks so that you don't have to constantly go back for another doctor order to get a test?
Yes. And they're happy to do it.
Sure.
We haven't had any physicians say, I'm not going to do that.
So how long is it taking you to get your results back?
We're now at the point where we're getting them 24 to 48 hours. We don't get anything beyond that really anymore.
And last question I have here is, can you talk about the testing machine that you mentioned, how accurate it is?
Yeah. Sure. So you can go online and look up Quidel and the Sophia, what we did is we bought them because we really want instant testing, right? Quick instant testing, and we knew that when we bought them that they're one of those emergency use FDA approved type thing where they put it out really quick. So their study was based on a real small sample, right? And so the study that the samples basically said, if you get a positive, it's like 99 something percent for sure it's positive. If you get a negative, it's only like 87.5% sure it's a negative, right? So we figured we would play with it, and as in the name of research and development, right? And we're having a kind of fun with it because every time we test, we would test, we'd use the Sophia, but then we'd do the PCR test. And so we're doing some comparisons and sort of using it on ourselves as well. And so we actually identified two of our executive incident command team members tested positive on the Sophia. And then that was backed up by the PCR test. Those tests were $23 a piece. But then now the government has confiscated the 4 remaining tests that we bought, and I guess they're being redistributed. I could not at this point rely on those testing results solely. I wish I could.
Thank you. That's all I have in the chat.
All right, that's Jill. That was amazing. Learned a lot myself. So thank you so much for sharing. We're going to hear from you now. So thank you for staying to the end. And we've got a couple polls, and we'd love to have everyone participate in these polls. So we really, again, it helps to inform where we go in future sessions. So let's launch the next poll. And this is really about your communication strategies. So Janet, I'll have you launch. Here you go. Which of the following do you utilize to communicate with your stakeholders? This is multiple choice, so feel free to check as many that are applicable to your organization. So which communication strategies are you using? Go ahead and click on the ones that are important to you. Give me just a few more seconds. So this is where, if you're multitasking, it's time to come back and participate in the poll so we can really understand what you have utilized and where you have found success. All right, Janet, we'll have you close it. It looks like email is number 1, followed by newsletters, letters, memos. Number 2, your website has been a big one, phone calls. And social media, 65% of you say you're using social media. So great, let's go to the next poll. Regarding COVID testing, what is your greatest challenge? And this is just one. COVID testing, what is your biggest challenge? All right, looks like we closed the poll, and 40% of you, 48%, it says that it looks like it's the time it takes to get the results. And Jill, if you're down to 24 to 48 hours, that's pretty darn good. All right, and I think, is that the end of the polls, Janet? Yes, that is the end of the polls. All right, so thank you everyone for joining. Next session, we're going to be talking about dealing with workplace grief and the acknowledgement that there has been so much loss associated with COVID-19. Jill, as you talked about the elders that you lost to death, and everyone that's on this call. Eric, you've talked about the workplace grief. So we're going to be very intentional next session, and we're going to talk about handling our grief. We are grateful to Project Echo and to this format. We are grateful to each of you and the work that you do each day. And Tammy and Jill, I'm grateful for your work and for sharing your expertise today. Thank you as always, Eric and Al, for showing up and sharing your wisdom as well with everyone. Take care all. I hope that you have a great week. Be safe, be well.
Thank you.
Bye-bye.
Bye.